Good afternoon, everyone. Thanks to all who joined in person. I would like to welcome you to Project Echo, a program that Dr. Santos and Dr. George founded. My name is Mocha Punkari. I'm the president of Project Echo here at Texas Tech. This initiative hosts monthly sessions with specialists from the Sciences Center to educate primary care in underserved areas of West Texas. The goal is to address key metabolic health disparities through case-based scenarios with the hope of reducing unnecessary labs, procedures, and ultimately drive down healthcare costs for patients. You may occasionally receive emails from the Project Echo team inviting you to host a presentation or participate as a panel specialist in the future. Keep an eye out for those exciting opportunities. Before we begin, a few quick reminders. If you're attending, please stay muted the presentation. CME credits are available for this event, but you must complete the evaluation survey at the end of the presentation. We will have a reminder at 12:55. For those attending in person, please ensure you've signed in on the paper at the front. Oh, here you go. Okay. This educational activity is supported Texla Telehealth Resource Center, a federally funded program of FMRI and community health. Now I'd like to and Dr. Boss.
Thank you. All right, good morning, everybody. My name is Luke Bradley. I'm a first-year medical student. With me is Dr. Doss, the interim chair and fellowship program director of gastroenterology, as well as professor of medicine. Interim chief, excuse me.
My chair is here.
With that, I'd like to hand it over to Dr. Doss.
All right, thank you, Luke. Good afternoon, everyone. Thank you very much for inviting me to this novel initiative, which is exciting. And I am very proud to be part of it. And thank you all very much for giving me the opportunity. So today we decided to talk about a case of pancreatic cancer that was masqueraded by some other symptoms that are commonly mistaken for upper GI disorders. I don't have any disclosures to report, and our objectives of the talk would be to review the evaluation of dyspepsia, to identify the masquerades of dyspepsia and evaluate how telemedicine may expedite early evaluation and intervention in this kind of patient population, and to review in brief, of course, on various aspects of diagnosis and management of pancreatic ductal adenocarcinoma. And I will stop here, and I will let Luke to run the case from here, and then I will be coming back when my turn is up there. Yeah, go ahead.
All right. So the case is a 76-year-old South Asian male who presented reporting a 3 to 4 month history of some epigastric discomfort. In addition, he reported a weight loss of 20 pounds and some fatigue over this time. He tried some over-the-counter remedies, some antacids and antiflatulence, which did not alleviate his symptoms. Otherwise, he does feel well and did report a decent appetite and had no other major complaints. So his past medical history included hyperlipidemia, diabetes mellitus, and benign prostatic hypertrophy. His past surgical history was unremarkable, although he did have an EGD and a colonoscopy done more than 10 years ago, which were also unremarkable. His family history was negative for pancreatic or colorectal cancer or any other cancer. His medications included aspirin, tamsulosin, metformin, and atorvastatin. And then finally, he denied any lifetime use of alcohol, tobacco, or recreational drugs. Furthermore, the ROS was negative except for the symptoms that were already mentioned in the HPI, and the physical examination showed normal vitals. Of note, the BMI was 21 on the lower end of normal, but otherwise the physical examination was unremarkable. So to summarize the case, we have a 76-year-old South Asian male with a 3 to 4 month history of upper abdominal discomfort, primarily in the epigastric region, accompanied with a 20-pound weight loss and some fatigue over this time. His BMI was 21. His past medical history included diabetes mellitus, for which he's treated on metformin only. His family history was negative for any cancer, and his social history was notably negative for any lifetime use of alcohol, tobacco, or recreational drugs. I'll hand it over to Dr. Das.
Okay, well, good job, Luke. So I would like to open the floor for the audience here, especially my residents and medical students. Based on the case and case summary given, do you guys have any differentials in your mind so that you can plan your workup? Maybe at least 5, maybe 10 differentials. Can I have some support from the audience? Any differentials that you may have in your mind? Anyone can answer, but I'm looking towards the residents. Any biliary cause? Okay, biliary, yes, biliary etiology, biliary pain, biliary colic, okay. Such gastric cancer, yes, right on target, okay, gastric cancer. Any other differentials? Common things, common guys? Huh? Of course, yeah, pancreatic cancer, the topic is the giver, right? Okay, yeah, sure. But as I said, common things are common. So think common. I mean, huh? Ulcer, right, peptic ulcer disease, excellent. Yes, peptic ulcer disease. Other common things? GERD, yes, absolutely, right. Those are the things that these patients will be, moving from one doctor's door to the other doctor, right? Not getting the diagnosis or getting over-the-counter PPI or Pepcid or things like that, and reassurance, right? Okay, so anything else that you can think of? So we have GERD, we have peptic ulcer disease, we have anyone think about some psychological or, psychosomatic problem? Non-ulcer dyspepsia, excellent. Yes, functional dyspepsia, right. That's exactly what I was looking for. So non-ulcer dyspepsia and dyspepsia, biliary etiology, pancreatic or gastric malignancy, gastroesophageal reflux disease, and so forth, okay? So this is very important that this is the population that we often, or maybe we delay in diagnosing their underlying etiology. That's why this was a bit striking to me and to bring it to this presentation today. So let's see what we have. All right, so sorry for that very tiny prints there. And as you can see there are multiple etiologies for dyspepsia listed. And it also mentions, if you look towards the end, abdominal cancer, especially pancreatic cancer. So don't forget, this is something that we don't have a lot of treatment really, and it's a very lethal disease. All right, so I wanted to ask you, or maybe we can follow this slide together. From the case summary, why would you think that this patient is not probably having a functional dyspepsia or non-ulcer dyspepsia? What are the alarm features that you can find in this patient from the residents or the fellows' point of view? Weight loss. Okay, age, right? He is 70 plus. Okay, weight loss. Okay, what's that? Huh? Ethnicity. Well, to be honest, actually, he's South Asian, so ethnically, he is not at very high risk for the cancer that you're talking about. But if you're talking about the gastric cancer, yes, he probably on the higher end of the gastric cancer. But yeah, I will take that point. Okay, what other alarm features that he had? So we found the age, ethnicity, we found the weight loss. What else?
Does he have anemia?
Not clinically, no clinical evidence of anemia, but we will give you labs in the next slide. But from the case summary, what other alarm features or what is some conditions that he has, or risk factors, I should say. See, the patient was diabetic, right? So diabetes is a risk factor for pancreatic cancer. And don't forget that almost 50% of the patient population will have diabetes at the time of diagnosis of pancreatic cancer. A new onset diagnosis of diabetes mellitus could be the predictor or the indicative of pancreatic cancer too. So if you look here, age more than 50, family history of upper GI malignancy, unintended weight loss, GI bleeding or iron deficiency anemia, as you were asking, dysphagia, odonophagia, persistent nausea, vomiting, abnormal imaging, suggestive of any organic disease. Okay, so we'll talk briefly about the dyspepsia. So what is dyspepsia? According to the Rome 3 criteria, it is defined as a dyspepsia as one or more of the following 3 symptoms for 3 months within the past 6 months of symptom onset. So as you can see here, postprandial fullness, early satiety, and epigastric pain or burning. And I just put this algorithm here so that we know how to evaluate this patient. As you can see here, a patient with dyspeptic symptoms, and if they have alarm symptoms and they are older than age 50, and you proceed with an EGD for them, you don't give them reassurance without working them up. PPI is not the treatment for them. You have to identify if they have an underlying organic disease that could be fatal, especially if there are any alarm symptoms. And if you find something, or if you don't find something, then you continue to work them up. On the other hand, if they are age more than 50, no alarm symptoms, but you can test and treat for H. pylori or trial of PPI. And if there is no improvement, you can do the EGD. And if it is negative, you can go back to that, the bottom box, which says that evaluate for other causes. Maybe think about the dietary modifications, try some TCAs or SSRIs, or psychotherapy, prokinetics, et cetera, for non-ulcer dyspepsia. But more importantly, we should not forget that these are the patients that in the back of our brain, we have to think about something organic may be present. So we cannot just stop if they have weight loss, if they are age more than 50, they have other risk factors that could, put them at higher risk for malignancies. Okay, and I'll turn over to Luke for the lab results and rest of the case.
Okay. So some labs were drawn on this patient, and they did show a very mild anemia and hyperglycemia attributable to his diabetes. Of note, the liver enzymes and the bilirubin were not elevated, however. So the next step, an EGD was done, which showed a mild gastritis as well as a small gastric polyp right here. However, the patient did not show any signs of gastric outlet obstruction, as you can see by a normal antipyloric region and duodenal bulb. Furthermore, the patient had a normal major papilla with no distension and duodenum, and then the path also showed he was negative for H. pylori. So then after the EGD, a multiphasic CT-enhanced abdominal CT was done, which I will now run you through. Here's the liver, stomach, and the spleen. And as the pancreas comes into view here, you can see that it is atrophied, and the pancreatic duct is also dilated. And then we'll move down into the head of the pancreas here, and you can see a large, irregularly bordered, hypodense mass that's encapsulating but not showing signs of infiltrating the superior mesenteric artery. Okay.
And we also did not appreciate any metastatic disease at this point of our evaluation.
Yeah, the CT does not show any liver metastases right now. Okay. So then let's move on. There we go. Okay, so following the CT, an endoscopic ultrasonography was performed. And once again, you can see a large, densely hypoechoic, heterogeneous, irregularly bordered mass at the head of the pancreas. And then here on the EUS, the mass does appear to demonstrate some invasion into the superior mesenteric vein, as well as possibly into the portal vein. And then right here, a fine needle core biopsy was performed using EUS guidance, which was then sent over to the path lab. Okay. So over here is a comparison slide of healthy pancreatic cells demonstrating normal cellularity and architecture with well-differentiated cells organized into acini.
One comment to make here, this is normal pancreas cells from the same patient. So our pathologist gave me this slide so that you can appreciate the normal to the degeneration into the abnormal and further undifferentiation of the tumor cells. And Luke is going to explain that too.
Yeah. Okay. So over here in the middle is another biopsy of the patient's tissue. This shows excessive growth of dense fibrous connective tissue, also called a desmoplastic reaction, with infiltrating malignant cells throughout and a loss of the normal architecture.
Which is on this image that you can see the normal cells with acini formation, glandular formation. They are architecturally intact with normal amount of stroma that they should possess.
Okay. So then this slide over here on the right also shows dense fibrotic tissue with infiltrating malignant cells once again, and a marked decrease in cellularity, which is showing a moderate to poorly differentiated invasive adenocarcinoma. And then, anything else?
Right,
ahead.
so if you go back to, so the tumor is so moderate to poorly differentiated, as you can see on this, it is densely fibrotic. It is showing severe desmoplastic reaction, and we will have few slides down the session here. We will see how the pancreas tumor can be resistant to many treatment and how we can actually learn more about targeted treatment for this kind of pancreatic adenocarcinoma. Down in the horizon. Okay.
Okay. So finishing it off, the labs from earlier, some baseline tumor markers were also measured, which included an elevated CA 19.9 and a CEA that was within the normal range. Now I'll pass it back over to Dr. Doss to finish this up.
All right. Good job, Luke. Thank you so much. All right. So I'm going to go over the pancreatic cancer in brief. So why is that very important? And before we go into that, let me just refresh ourselves with a little bit of anatomy. I know we all know this, but it may be a refresher for especially the students. So pancreatic cancer or pancreatic ductal adenocarcinoma, we will be calling it PDAC here. So pancreas is located in the upper abdominal area in the retroperitoneum, as you can see. It is very closely related to the bile duct, superior mesenteric vessels, as well as celiac trunk, abdominal aorta, vena cava, portal vein, and liver hilum, and then celiac artery, and also the spleen, kidney, and all those organs, as you can see, are there. The head and neck of the pancreas resides within the C of the duodenum, as you can see here. And anatomically, the head and neck is divided by the impression of the superior mesenteric vein, which literally demarcates the neck. So to the right of it is the head, to the left of it is the body. And then when it reaches beyond kidney, then we call it pancreatic tail. And this is important. A lot of cancers, I think 70% of the pancreatic ductal adenocarcinoma arise in the head of the pancreas. And of all the adenocarcinoma, 95% of the pancreatic cancer begin in the exocrine cells. And not to mention that pancreatic cells have two functions. One is exocrine function, which is the formation of the digestive juice, and endocrine function, which is the making of the hormones like insulin and glucagon to maintain our glycemic homeostasis. So pancreatic cancer is very deadly, as I mentioned. As you can see, this is the 2025 statistics from the SEER database. As you can see here, in the year 2025, about in both genders, about I would say 67,000 new cases. And if you look at the death, out of 67,000 new cases, about I would say about 53,000 will die. So it's that deadly. And in terms of the mortality, it is actually in the third leading cause of mortality from the cancer-related deaths. And it is actually in the rise of becoming second leading cause. And it is anticipated that in 2030, it will be the second leading cause from the cancer-related mortalities, because treatment has improved for other malignancies in our body, but hasn't improved as much for pancreatic ductal adenocarcinoma. And you can also see the 5-year survival rate is also very poor. And though it depends on the stage of presentation, if it is at the metastatic stage, usually less than 3%, and regional disease about 12%, and localized disease about 37%. So it has, in general, very poor prognosis. So we need to know what are the risk factors of this pancreatic cancer so that we can prevent from these risk people, prevent these people from having pancreatic cancer. So as you can see there is that, there are some risk factors like smoking, long-acting diabetes mellitus, and non-hereditary and chronic pancreatitis, and obesity, and also non-O, blood group. And you can see the relative risk of their association. And these are the genetic cancer syndrome patients where you have, hereditary pancreatitis group, you have familial atypical multiple mole melanoma syndrome, and you also have the Bujager syndrome, you have MEN, you have von Hippel-Lindau, you have Leif-Ramoni syndrome, you also have ataxia, telangiectasia mutation gene, et cetera, et cetera. There's also a familiar, pancreatic cancer syndrome. And when you have one affected member of the family present, you have 2 times increased risk of pancreatic ductal adenocarcinoma in that affected person. If you have 2 affected member in the family, the incidence goes up by 6-fold. And if you have 3, it's 30 times higher. So this is very lethal disease, and these are the patients who are at very high risk. And towards the end of the session, we will talk about some screening so that we can get these patients under the screening to prevent the incidence of the new cancers. And if you can look at this here, pancreatic ductal adenocarcinoma, as I mentioned, 85 to 90% cases are sporadic. About 5 to 10% have familial risk, and 3 to 5% has genetic syndrome association. So pancreatic cancer is lethal because the diagnosis is difficult. Why? Because the symptoms are not really very specific to it. As I mentioned, it masquerades many other conditions, and often it is considered to be a benign, etiology for the symptoms. If we are not thinking about it, we can miss potential, the golden period of time. And also the pancreas is hidden behind many organs like stomach, small intestine, liver, gallbladder, spleen, and bile duct. So patients may be, mistaken for those symptoms as opposed to the pancreatic cancer itself. How does the pancreatic cancer manifest? So a lot of time it's asymptomatic, especially if it is early in the disease process. As the cancer progresses, patient will have some abdominal pain, and typically patient will complain of the pain in the upper abdomen, maybe in the right upper or left upper quadrant, and it may radiate to the back. And weight loss is there, muscle weakness is there, and you also have jaundice, especially if it is the tumor involving the head of the pancreas with involvement into the bile duct. A colic stool secondary to the obstructive jaundice, dark colored urine secondary to the obstructive jaundice again. And as I mentioned earlier, 50% of the patient with pancreatic cancer will have diabetes at the time of diagnosis of the cancer. And as I mentioned, in a patient more than 50 new-onset diabetes, you should always think about something abnormal in the pancreas. So always, think about doing some screening if possible. Fatigue is also another way of manifesting this disease. And patients will manifest with more than one symptoms often. I kind of talked about it earlier, that head has the majority of the cancer and rest in the body and tail. So what are the tests that we use to diagnose and stage the pancreatic ductal adenocarcinoma? So of course, to learn about the patient's overall well-being, we like to know about the blood chemistry, and we can do a CBC CMP as we did in our patients. And once we have the diagnosis confirmed or we have a suspicion of the diagnosis, we can get some tumor marker. Of note, it is not recommended to just go ahead and order the tumor marker because they are neither specific nor sensitive. But if they're elevated in a patient with pancreatic cancer, they may help you in monitoring the prognosis, response to the therapy. And commonly tested tumor markers that we do, CA19-9, CA125, and CEA. In some patients, especially if they have Lewis antigen negative on the RBC, they can have normal CA19-9. I just had a patient diagnosed with a invasive adenocarcinoma, absolutely normal CA19-9. So CA19-9 doesn't tell us that the patient has poor prognosis or good prognosis or cancer or not. When you include the CA19-9 and CEA and CA125, the sensitivity specificity may be slightly higher. But again, one test alone may not give you a lot of information. We rely a lot on the imaging studies, and traditionally, the best study would be the MRI pancreatic protocol, which is without and without contrast and with a thin sectioning of the body. If we cannot get it, CT pancreas protocol is also equally important, but the recommendation is for MRI. However, we know how difficult it is for us to get MRI, so we often ended up doing a CT pancreas protocol. Know that single phase CT may not be as good as multiphasic contrast enhanced pancreas protocol CT scan. You can also do the PET scan, and you can add PET scan to the CT, which is PET CT. Abdominal ultrasound, we can get it, but if the tumor is big enough and if the patient doesn't have a lot of gaseous distension of the bowel, you may see a mass, or you can at least see the bile ducts and all those. So that's good for the biliary etiology or biliary evaluation. Endoscopic ultrasound, probably by far the most among these modalities. And endoscopic ultrasound and MR, they have equal sensitivity, specificity. They are very close to each other in their performance. The benefit of endoscopic ultrasound is that we are very close to the pancreas. We have very high definition imaging of the pancreas. Smaller lesion, less than a centimeter, that MRI will miss it, US won't miss it. And you get the added benefit of biopsying even less than 5 millimeter lesion. So you get early diagnosis thereby. So US is higher on the imaging studies for evaluation of the pancreatic cancer. ERCP, sometimes we diagnose these patients. We can do cholangioscopy, cholangiography. We can take the biopsy from the biliary stricture, and that gives us the diagnosis, especially infiltrative type of adenocarcinoma. Same thing for the percutaneous cholangiography, similar to ERCP. And laparoscopic staging is also important. Patients, when indicated, surgeons may do laparoscopic staging before they pursue the surgical therapy with curative intent. Because if they see peritoneal seedings or nodularity, then that's the end of the surgical history there. So they will just, close the abdomen and come out, unless there are palliative gastrojejunostomy or other surgical needs would be there. Biopsy, of course, biopsy can be obtained by CT or endoscopic ultrasound, but traditionally, endoscopic ultrasound is the way to go because it's safer and you have less complication risk compared to the percutaneous biopsy. More importantly, you have the less risk of peritoneal seeding when you do the transduodenal biopsy or transgastric biopsy using endoscopic ultrasound guidance. All right, so we talk about the pancreatic protocol. I just thought of putting that in there so that we know what exactly pancreatic protocol is. And I also put the slide for the pancreatic MRI protocol. So basically, as I mentioned earlier, these are cross sections are very thinly sliced. So they're recommending less than 3 millimeter, maybe even sub-millimeter, so that you can get the thinner pieces and you don't miss the very smaller lesions. So this is very important that we all know we're on the same page about the pancreatic protocol. You can go through it here. So it's a multi detector CT, and thickness should be less than 3 millimeter, maybe even smaller if possible. And interval should be also very, very, very thin interval. And oral contrast as well as IV contrast are recommended. And you have to be able to reformat the images. Like, you should be able to do the sagittal. You should be able to do the coronal imaging from your cross-sectional images. So this is very important that we all know. And this is what pancreatic protocol CT is: multiphasic, thinly sliced with PO and IV contrast CT scan. And then same thing for the MRI. More importantly, in MRI, the slices are a little bit bigger or thicker than the CT, but probably because of the modality variation, but less than 6 millimeter on the slicing. And then you have to have the diffusion weighted imaging that can tell us, whether this is inflammatory versus malignant based on the diffusion weighted distribution of the contrast in the tumor cells. So the staging, we'll go through this. I'm going to skip this. So we go by the AJCC, American Joint Committee for Cancer staging system, which is a TNM system. And we don't have to memorize it, but we should have a basic of it so that we know which cancer is surgically resectable, which is not. And I will just go through this. I put this cartoon there so that we understand it. So pancreatic adenocarcinoma, stage 0. This is like, you have a very small tumor and the tumor cells did not spread anywhere. So it's locally, it's just localized. So stage 1A and 1B based on the size. So as you can see here, stage 1A is less than 2 centimeter and stage 1B is somewhere between 2 to 4 centimeter, not quite 4 centimeter. Now, so if you look at the stage 2, you have A and B there. So this is stage 2A when you have a tumor around 4 centimeter and you have spread of the tumor to a couple of lymph nodes. So that's stage 2A. And then you have stage 2, stage 2A is a 4 centimeter, but stage 2B, you have 1 to 3 lymph nodes, stage 2B. And then this is stage 3, this is stage 3, when you have a tumor, bigger tumor, but more lymph nodes involved, and tumor may be reaching to the, vasculature. Like, you have the mesenteric arteries there, mesenteric vessels, you have the common hepatic artery or hepatic artery proper, you have the portal vein, you have the celiac artery. So as you can see on the schema there, so that's stage 3, locally advanced. And this is stage 4. Basically, you have the distant disease. As you can see that on the left side cartoon, it shows that how tumor cell can metastasize. You have lymphogenous or lymphatic spread as well as hematogenous spread. And of course, you have local spread too. So this is important, and I would like all of us to know that resectability status, and I will go a bit faster for the sake of time. So as you can see, resectable lesions are, like we talked earlier, stage 1, maybe stage 1B, before it's stage 3, I should say. They're resectable because there is no arterial encasement or invasion or vascular invasions, venous invasions. Borderline resectables would be, as you can see there, they have some degree of invasion into the vasculature, and tumor is contracting less than 180 degree of the SMA or less than 180 degree of the portal vein or superior mesenteric vein, and if you have the tumor in the pancreatic body or tail, the tumor may be contacting the celiac artery or celiac trunk and maybe less than 180 degrees. So those are borderline resectable. Those are the patients who undergo neoadjuvant chemotherapy before the surgical restaging. And then if the chemotherapy shrinks the tumor, contain it, and separates the tumor from the vasculature, then they can go for the surgical resection with adjuvant chemotherapy thereafter. And then locally advanced disease are solid tumor contact, more than 180 degree involvement, and in the pancreatic body tail, of course, celiac artery and other organs involvement. So there is a cartoon that I found. This is kind of interesting and very nice to remember. So this is a continuum of the pancreatic cancer. As you can see, at the very bottom, no arterial or venous involvement. Of course, that's where we are hoping to cure the tumor if we can surgically resect it with negative margin or R0 resection, we call it. And if you go upwards, you can see attached to the other organs, still resectable, because if it is attaching, infiltrating the duodenum, that's the Whipple specimen is going to come out with it, so you can still resect it. But if it is attaching to the vessels and all those, then it's going to be unresectable. And of course, when it is distant metastasis, it's not resectable at all. Now, before we move on to the treatment, I would like to quickly go through here a little bit, and I won't spend a lot of time. These are the oncogene and tumor suppressor genes that are commonly mutated in pancreatic cancer. As you can see, KRAS is more than 90% and mutated. And if it is mutated, so that's an oncogene, and it signals the cancer progression and or unregulated cellular proliferation. On the other hand, the red circles are tumor suppressor genes, and if they're mutated, they cannot suppress the tumor biology anymore, so growth goes unchecked. This is very important. This is where the research is ongoing, and these are where the targeted therapy are probably going to come forward for us. And I think we have some immune therapy probably targeting some of the the ligands there. So this is very important to know, and I was intrigued to learn about it. As you can see, there are four processes that are happening here, And you can see on the top, there's abundance of the deposition of the matrix or stroma that we showed in our slide. Desmoplastic reaction, we call it. So the pancreatic stellate cell that lays down a lot of fibrotic material, and that actually reduces the vascularity, makes the tumor hypoxic, that further reduces the drug delivery, and also other nutritional thing. And the tumor escapes those mechanisms and tries to find out other ways to make its energy. As you can see there, low vessel density there. I will show in the picture. There are studies done on the mice that shows that tumor has low vascularity compared to the peritumoral disease tissue. Cancer-associated fibroblast that can also be targeted, and above all, the lack of cytotoxic T cells in the pancreatic tumor cells could be a target for future ongoing treatment. As you can see here, there are a lot of pro-inflammatory cells are there, but there is no cytotoxic T cells there to suppress the tumor biology. And this is same thing, kind of recapitulation. And so that's why the heading here is that tumor microenvironment. You call it microenvironment, and they are calling it, they're comparing it to the Achilles heel, which is the weaker part of in Greek mythology of Achilles heel. But anyway, so this is another immunohistochemical staining that shows that a lot of fibroblastic growth. You can see in this picture, you can see there are a lot of immune cells they are in blue, and also in the next slide, I'm going to show you these are the immune cells that are in blue, and this is the tumor which has less vascularity. As you can see, these are vascular here. This is the peritumor. This is the demarcating line. So the tumor has less vascularity. That's how it's evading all those chemotherapy that we have available. It's not penetrating into that. And to overcome that, there are different approaches are in the development, but without much benefit so far. Tumor microenvironment, we kind of talked about it, and there are different targets. This is just the repetition with some ligands that are available. Like you can see, they are targeting different areas. What are the principles of systemic therapy? So these are busy slide, but I'm going to be pointing out only two important things here. So the staging is very important. One thing I would like you to know that whether or not this is resectable or unresectable, that's the decision we have to make. If it is resectable, of course, they're going for surgery based on the surgical findings. Adjuvant chemotherapy may be pursued. If they are borderline resectable or unresectable or metastatic, then they are going to go for the chemotherapy. And one thing that we need to know, first-line chemotherapy are two, FOLFIRINOX or gemcitabine plus albumin-bound paclitaxel. So if we remember from today's talk, first-line treatment for pancreatic adenocarcinoma at any condition, unless they are just localized tumor, FOLFIRINOX. That's the one that is first line, and you will see it will keep coming. So I'm gonna go quickly on this, and because these are repetition, I just wanted to familiarize ourselves with this, but not much really to know here. All right, so radiation. When do we do the radiation therapy? So if the patient is resectable or borderline resectable, or if the patient is resected and there are some margins positive and they can still get the adjuvant chemotherapy. If there's a locally advanced tumor, if the patient is having a lot of pain, bleeding, and etc., we can do the palliative radiation therapy. And if there is a recurrent cancer. So these are the 5 situations where the radiation therapy is used, and it can be concurrently used. I'm going to skip that for the sake of time. How do we manage the obstructive jaundice, and how do we do the tissue acquisition? So it is recommended by NCCN guideline is that when patient presents to you with obstructive jaundice and there is a tumor, it is recommended that you do both at the same time. Of course, you drain the bile duct, you put a stent, and etc. Then using the US guidance, you get the tissue. And they prefer the self-expandable metal stents, which is what we often do. But sometimes we also wait and see if we can confirm the tumor and etc. and go from there. So principles of surgical technique. So as I mentioned earlier, we have different types of surgery. So for the head and neck cancer, we have the Whipple surgery. So there are different kinds that didn't show any outcome benefits. Whether it is pylorus resolving or traditional gastrojejunostomy, Whipple surgery doesn't really matter as long as the resection margin is negative. And if it is for the body and tail, then you go for the distal pancreatectomy with splenectomy. And there are also variations these days, and some surgeons are also doing spleen sparing surgery for certain conditions. This is important for us from the medicine standpoint. What are the principles of palliative care? Principles of palliative care in pancreatic cancer patients. So we talked about the biliary obstruction. Of course, we palliate the biliary obstruction by stenting. We have, if we cannot cannulate, we have IR-guided percutaneous drainage or US-guided rendezvous procedure that we can do. Patient often present with gastric outer obstruction. And so we have stenting, we can do surgical gastrojejunostomy, we can do endoscopic gastrojejunostomy, we can do endoscopic gastrostomy and surgical J-tube, we can do a surgical G-tube or J-tube for feeding and venting purposes. So we have many ways to palliate this patient. This is important, especially if they're terminally ill, they need palliation. These are the remedies that we can provide. They are prone to thromboembolic disease, so anticoagulation is recommended. Bleeding from the primary tumor site can happen, and you can do therapeutic endoscopy, inject into the tumor, you can do radiation therapy, and etc. Pain, I will talk about it. I have a couple of slides, so I'm going to skip it here. Anorexia, very common in those patients. So TCAs, SSRI are very helpful in those patients. And depression and fatigue, again, very common. So psychotherapy, antidepressants are very important. Don't forget that patients with pancreatic cancer, often in our patient had atrophy of the pancreas. So often they will have pancreatic exocrine insufficiency. So they will benefit from the PART therapy, which is the pancreatic enzyme replacement therapy, to maintain their weight gain, bring their appetite back, and reduce the metabolic complications from the pancreatic exocrine insufficiency. Pancreatic cancer associated pain management, this is very important for us to know. As you can see on the x-axis, this is the increasing pain intensity, and you have different things that you can see at different stages you can do from the top to bottom. You can try the radiation therapy at some point, you can do neurolysis, you can do high intensity intralesional ultrasound, you can do Tylenol or COX-2 inhibitors, you can do opioids, and et cetera, et cetera. Pancreatic enzyme and stents in the pancreatic duct, because the pain comes from the pancreatic ductal obstruction, tissue infiltration, invasion of the nerves by the tumor. So that's where our service can be handy for those patients. Often we do celiac plexus block and celiac plexus neurolysis as a combination therapy when the patient's quality of life is important and they are having too much side effects from the opioids. We can do endoscopic ultrasound guided celiac plexus block and neurolysis for these patients. So this is a study, there are multiple slides from multiple studies. As you can see, in almost all of these studies, celiac plexus neurolysis reduced pain and improved the patient's quality of life, improved their mood. What are the barriers? Of course, not every, usually celiac plexus block is available in academic centers, so you don't have the community advanced endoscopies doing this for them. There is a concern for the drug addiction, so providers are apprehensive of giving them the medicine, and they forget that these patients are to be having pain. So that is something that we can do better for these patients. And of course, we are useful. If the patient is suffering, we can do our part. We can do the block, we can ablate the nerves, and et cetera, so that they have at least quality of life during their terminal stage. This is a quick review. I will take just a few minutes here and almost towards the end of it. And this is very important, and we can skip a few of this, but this is the AGA, American Gastroenterology Association, recommendations for the people to be screened for pancreas cancer. This is the key slide today that I want you to remember. These are the patients that we need to screen so that we can prevent new cases. We can reduce the incidence of the pancreas cancer, although the percentage may be low. as we talked earlier, maybe about 15-20%. So best practice advice 1, pancreas cancer screening should be considered in patients determined to be at high risk. We talked about the familial cancer syndrome patient with, more than one family member involved. We talked about the genetic cancer syndrome patient with multiple, genetic cancer syndrome associations. Best practice advice 2, pancreas cancer screening should be considered in patient genetic syndrome. We talked about it already. Best practice advice 3, genetic testing and counseling should be considered for familial pancreas cancer relatives who are eligible for surveillance. A positive germline mutation is associated with an increased risk of neoplastic progression. Practice advice 4, participation in a registry or referral to Pancreas Center of Excellence should be pursued when possible. And clinicians should not screen average risk individuals for pancreas cancer. I myself don't quite agree with this, but that's just my opinion. When I see in my clinic a patient with chronic pancreatitis, smoking, diabetes, I cannot stay, quiet or anxiety-free without screening those patients. So I do screen them. That's just my opinion, my practice. But the society says we don't have to probably screen them because chronic inflammation is a condition where the tumor can settle in. Best practice advice 6, pancreas cancer screening is high-risk individual should begin. This is important, when to start the screening. So ideally should be at age 50 or 10 years younger than the index case. There are variations. If you have a hereditary pancreatitis or hereditary pancreatitis gene mutation, you start at age 40. If you have Poijoger syndrome, you start them at age 35. And if they have cancer at 35, you go forward 25 to screen their relatives. So 10 years earlier than the index case. So this is important. And how do you screen them? So we still have a couple of minutes, right? So you screen them by cross-sectional imaging or endosonography. So you see CT is not listed. Okay, MRI and endoscopic ultrasound. You do both. They're not saying and or, they're saying both. MRI and endosonography. But we know the reality. If we order an MRI, it takes 3 days in the hospital to get it. It takes 2 months in the outpatient setting to get it. So on the other hand, CT, we get it done in a week or less than a week sometimes. So there are biases there. The availability is not there. So as long as you do it, I think we're fine. But these are the recommendations. So the target detectable pancreatic neoplasms are resectable stage 1 pancreatic ductal adenocarcinoma and high-risk precursor neoplasms. So those are the targets that we're trying to detect so that we can prevent the progression from pancreatic intraepithelial neoplasia stage 1, 2, 3 to adenocarcinoma. Yeah, and then how frequently we should screen them. So screening intervals of 12 months should be considered when there are no concerning pancreatic lesions, with shortened intervals and the performance of the US and or the performance of the US in 6 to 12 months directed towards the lesions determined to be low risk. So again, if you have no lesion 1 year, if you have some concern, you can bring it down to 3 to 6 months and use your judgment. I'm going to skip the rest. And so I'm going to go to the summary here. In summary, pancreatic cancer carries a poor prognosis. Be aware of the masquerading symptoms. Early detection is a challenge as the disease often manifests late. The disease metastasizes also rapidly. Screening of the pancreatic ductal adenocarcinoma of high-risk population is recommended. Insurance doesn't pay for it. The contrary to this, all the society guidelines are saying, even National Cancer Institute, our NCCN guidelines are saying to do it, but United States Preventive Task Force say do not do it. So we go with the other society in our practice, and that is true for all academic centers of excellence in pancreatic cancer. We all screen these patients for those high-risk groups. When feasible, appropriate staging is mandatory in the management of the disease. When feasible, surgery should be offered to the appropriate group of patient population and should only be performed in the absence of distant disease, unless you are planning to do palliative surgery for those patients, not necessarily curative intention is there. Systemic chemotherapy should be offered to the appropriate group of patient population based on the current guideline recommendations and performance status of the patient. FOLFIRINOX appears to be the first line, along with albumin-bound paclitaxel and gemcitabine. Adequate and appropriate palliative measures should be offered to all patients, irrespective of cancer stage, which include the pain and jaundice and all the other things. A prompt referral to a medical center specialized in multidisciplinary team-based provision of cancer care will earn extra miles for the management of these patients, often in an expeditious way. When possible, use direct communication with the cancer care team. And that is my message to the audience. If you think that your patient needs urgent referral, you can directly contact us. And usually within a week or less than 2 weeks, these patients are seen, had US done, biopsy done, even often diagnosis given to them, because we expedite any patient that we get on pancreatic cancer. So this is just to summarize. If there is a metastatic pancreatic cancer, goes for systemic therapy. Local pancreatic cancer, locally advanced chemoradiation, systemic therapy. Borderline resectable, chemoradiation neoadjuvant, if possible surgery, and if needed, adjuvant chemotherapy. Of course, if it's resectable, surgical resection. If the margin positive or the tumor is big, you give some adjuvant chemotherapy. All right, so I want to say a few words about the telemedicine, how we can be useful. Thank you, Glenn, again, for your valuable help in this. Early detection and diagnosis. We can be useful in remote evaluation of symptoms like jaundice and pain of these patients, and maybe expedite, evaluation in the clinic if we are involved early. No matter how, phone call, email or text messages, either way. Pre or post-operative care. We can help in virtual recovery monitoring and complication management. That goes more to my surgery colleagues. Access to specialists, connecting rural patients with expert care. Yes, of course, that's our goal in the West Texas. We miss out a lot of patients because of lack of information and lack of availability of the providers providing this care. So we could be useful, refer them to our cancer center or reach out to us directly. Multidisciplinary coordination, which is the key in cancer care, and we do have it. We have multidisciplinary tumor boards, we have multidisciplinary hepatobiliary and pancreatic conference every month, and we discuss these cases and take care of the patient. Symptom and side effect management, and we can do that for sure. Psychosocial support for the patient, and diet and lifestyle guidance. We can be useful in any of these need of our patients if we are contacted early in any way you can. So with that, I thank you all very much for your kind attention and support. I am ready to take any question.
I'm wondering about this idea that if I turn 50
Yes, sir.
and I have diabetes, I may have cancer. How does that work?
Good question. So, that's a risk factor. I don't think that, age 50 and diabetes, if it is new onset, of course, we have to worry about it. But if it is you are having diabetes already and then you turn 50, that's a different story. But if diabetes is coming at that age, I think because, the number that the studies quote is 50%. 50% of the patients with pancreatic cancer will have diabetes at the time of diagnosis. So that's why diabetes, new onset diabetes, could be a early predictor of the pancreatic adenocarcinoma. And that's it is recommended that further evaluation may be necessary. At least thinking in that direction may be necessary.
But does the tumor have the effect on the endocrine cells, or is it just?
I think that's what the involvement, maybe the involvement of the endocrine cells, and then leading to the altered regulation of the insulin and glucagon system. So that's why I think they are recommending that if there is because it can involve either although often is from the exocrine cancer cells, but you can have other cancers in the pancreas too. So very, very good question, sir. Thank you, as usual. Yes, sir.
I'm glad that we have a screening options now, especially for high-risk individual.
Right.
But the trouble with any form of screening is always the concern of false positives. How do you handle that when you have an incidental, like in the lung, if we have incidental nodules, we usually have a guidance on how we can predict whether it is a benign nodule or is it something that we go after? So is there a cutoff on, but in general, how do you manage incidental
Right.
pancreatic nodules?
Very nice. Incidentaloma is not uncommon. And I think that's where the multidisciplinary discussion comes. And, if there are no clear-cut criteria for us to be, for instance, if I see a tumor and obviously if it is seen on a CT or MRI, and immediately we're gonna go, do a biopsy of that. And then the biopsy will get the tissue. Sometimes, biopsy could be inconclusive. And in that situation, depending on the size of the tumor and depending on the other characteristics that we may identify on the cross-sectional imaging, we may say, okay, let us have a follow-up in 3 months, which is the commonest to do, have an interval follow-up and to see whether this is, regressing or progressing. The reason I say that, sometimes it is difficult, even when we do endosonography, it is difficult to separate a hypoechoic pancreatic tissue. Pancreatic tissue in general hypoechoic to some degree. But if you have a fatty infiltration and an area is fat spared, you will see that as a hypoechoic nodule and you regard that as a malignant lesion. So we biopsy that. Essentially, that's probably a normal fibrotic pancreatic tissue. So there are incidentalomas like that. And we review them with the radiologist ourselves or in our HPB conference. It usually happens at 7:30 every third Wednesday of the month with the interventional radiology, us, and hepatobiliary surgery, Dr. Onkeni and Dr. Mao. So we conduct those sessions and we have a consensus based on the review, and then we follow them accordingly.
Thanks.
Yeah. Yes, sir.
Dr. Das, thank you very much for this great presentation, and I would like to acknowledge the students as well,
Yeah,
for
they have been
helping us
phenomenal.
with this presentation. I would like my colleagues in the surgery department actually enjoyed working with you. I myself
Thank
enjoyed
you.
working with you, and
you're
I
very
think
kind.
it's still a problem though. Like we have a lot of famous people, Steve Jobs, Alan Trebek,
Right.
Alex Swayze, RBG, and what's in common with them is they all develop pancreatic cancer, and some of them develop really late on the stage. And I thank you for doing the staging, because I think it's very important to not just order a CT, but a CT with the pancreatic protocol, so we could see the images better. And the other thing though is sometimes we don't need, the surgeons does not need the tissue biopsy before being seen.
Right. Exactly.
Because sometimes we could, if it's a high suspicion and it's causing, obstruction, then they probably opt to remove that tumor.
Right.
And
Absolutely.
every now and then, I came from the Philippines, we're in, there are those who had tuberculosis actually presenting and masquerading as cancer,
Yeah,
which is the other way around.
Right.
But I think there are still a lot of rooms and improvement on screening process, and the
For
way it get paid and everything. So are there any new developments, especially, we're, the colon had CEA, we have CA 19-9, but you and I know that's not,
Right.
really a great tumor marker. It's the best we have right now, but it's not the best.
Right. So not to my knowledge that based on the studies that I did for this presentation, I did not come across any new modalities, but there were suggestions about certain tumor marker, as I mentioned, like CA, CA99 and CA125 and LICAM 2, I think there is another ligand. I never ordered it honestly here. So I just came to know about this new molecule that I don't even know our lab has it. So yeah, that's one. But again, you may get a little bit of gain in your sensitivity and specificity, but not as good as you get with the multi-detector CT or, contrast enhanced MRI pancreas protocol and or endosonography. So that's why I think those two are standing as an outlier among the other, screening modalities here. So they are the best performer at this point, and that's why they're recommending them. I was surprised that CT was not considered, and I understand why not. Sometimes when you look at the CT, sometimes it's very difficult because they are so isodense, and even MRI sometimes miss those things. And we feel fortunate for those patients when you do US, and we can identify them because we are so close to the lesion. And I think it does have, but the problem with our modality is that it's invasive. But good thing is that they are saying and, they're not saying and or. So they are asking us to couple them to enhance, especially in the high risk patients, of course, so that we remember the target lesions are pancreatic cancer intraepithelial neoplasm, like in their high grade dysplastic stage before they turn into a full blown cancer. So that's where I think the focus is: identify those lesions and take the next step. So, but no, other than this, no new modalities that I know of, sir. I don't know if that answered your question,
Yeah,
but
that's
yeah,
the
thank
answer.
you, sir.
My question. And now we have surgical oncology division, and we're hoping our promise is to be seen by them within 7 days of referral. So just like yourself, we're trying to see them as soon as possible.
Right. One thing I would like to mention is that we underutilize our geneticists. So patients with pancreatic cancer or wherever you think that there could be a hereditary component, it is not redundancy in referring them to the cancer center, and they have the geneticists. They go to the genetic counseling, and they go through everything, the pedigree and everything, and all the family history, and they run their genetic testing. So I think that is something that we can do for our patients with high risk. Any other question? All right. Well, thank you all very much. I appreciate it.